So in this COVID era, because we are far away from each other, but we have joined due to some technology advancement. And my namaskar to all of you. And so some people are also my teachers, and some people are also colleagues. So I'll just tell you one important thing is when there is a stress conditions and other parts are there. The important thing is one is anabolic hormone, that is insulin, and other are mostly catabolic hormone. And all the hormone available is insulin. It may be insulin resistance, it may be less production of insulin or beta cell dysfunction or any other cause. So likewise, depression is also mostly the problem of the serotonin, but comparatively, it is less understood as it is better understood in the cases of diabetes. But Madam has already told about that one third of this diabetes population they suffer from depression. So I will just tell about this epidemiology link between diabetes and depression, depression and diabetes complications, practical problems arising from depression and diabetes comorbidity, depression care in the patients with diabetes, medication, and summary. So epidemiology already, Madam has told that 31% of these people clinically relevant are having depression symptoms, and but person with depressive disorder, if the person is having depression, they are having 65% increased risk of developing diabetes. Means depression people are two-third more prevalent are developing diabetes. Then prognosis of both diabetes and depression in terms of different problems of complications like treatment resistance and mortality is worse when two diseases are comorbid and when they also occur separately. So the problem is mostly double or triple when these two diseases are comorbid. So common symptoms with diabetes that we come across that is like frequent urination, unusual thirst, extreme hunger, unusual weight loss, extreme fatigue, irritability, frequent infection, blurring of vision, bruise, slow to heal, tingling, numbness of hand and feet, recurring skin, gingival and bladder infections are there. These are very well shared with the symptoms of depression because depression also is having depressed mood and loss of interest in all pleasurable activities and other symptoms like weight loss and disturbances of sleep, mostly in the early morning insomnia and psychomotor retardation or agitation and fatigue, guilt feeling, worthlessness, hopelessness, and executive dysfunction and suicidal ideation. So these all mostly 30% of the symptoms they mimic with this both disorder and shared with both disorder. These are all causing diagnostic dilemmas. So link between depression and diabetes is there. So in the depression there is decrease, there is HPA axis hyperactivity is being HPA axis is being disturbed, and also there is activation of sympathetic nervous system. So when there is sympathetic nervous system is activated, there is increase of interleukin 6 and catecholamines. And with this disturbances of HPA axis, there is increase of the stress, this cortisol is increased. These all leads to insulin resistance, and with this insulin resistance, we know that type 2 diabetes is more prevalent. Hence, metabolic programming at the genetic level and undernutrition both in utero and in childhood, this also gives the predisposition to both diabetes and also depression. So, depression is also very well associated with this diabetes from the programming is also from this utero, and also we see most of the time also in the childhood also. And the risks of behavioral factors like depression, there is decrease of this physical activity. This decrease of physical activity is increasing obesity. As you know, obesity is a very good risk factor for type 2 diabetes mellitus. And when there is depression is there is lack of interest. And with that lack of interest, what happens to these people? The diabetic people, they are having decreased motivation to self care. So because of the decreased motivation to the self care, they are having poor adherence to this medication, diet, exercise, blood glucose monitoring, and these all lead to type 2 diabetes mellitus. So with this type 2 diabetes mellitus, when the person is no restricted to different foods and person is restricted to his tongue and to his diet, then there is some emotional problems. And along with this, also the insulin directly causes this emotional disturbances. Sometimes if the person takes more amount of medication, there is hypoglycemia. With this hypoglycemia, that also mimics panic disorder, and this emotional problems also leads to depression. So these are all bidirectional bidirectional methods for depression and also diabetes. So depression and diabetes complications are there. So we all know coronary artery disease people are more affected with diabetes, but there is also prospective association documented between the prior depressive symptoms and onset of the coronary artery disease with the people of diabetes. This means the person which is having coronary artery problem and also depression is prior, then they will more develop coronary artery problems with diabetes. And retinopathy is very common. And also if the person is having taking anti-diabetic medicine and also diabetes complications, they are having erectile dysfunction and diabetic foot disease. And erectile dysfunction is also associated with, and multiple somatic symptoms are associated with depression, as you know. And also with this treatment of SSRI, also there is erectile dysfunction. So depression and diabetes comorbidity, what we have to do? If then the patient is having depression, then diabetes symptoms overlap, or depression symptoms sometimes mimic diabetes symptoms. The patient is maybe unaware of depression and maybe primarily attribute to this change status to worsening diabetes self-care. So depression may be associated with onset or amplification of the physical symptoms. The patient may not sense. So impact is that the patient may not sense he or she is fully understood or supported by his or her clinician during the healthcare visits when physical or lab results do not correspond to the subjective complaint. This also, most of the time we see that the patient having depression is sometimes underdiagnosed, that you are correcting his findings of these lab findings, but the patient complaining physically more, which is having more complaint, and family members tells that this does not correspond to his lab finding, and doctor also does not corroborate to his subjective complaints. Then depression commonly associated with the difficulties with diabetes and self-management and treatment adherence. And the impact is patient may feel resigned about ability to make the changes that I know I am supposed to do, but what I am not supposed to do, but still I do the wrong things and I do not know why. So because depression, with this depression, patient is not that much of caring for his disease. Clinicians sometimes may feel also discouraged about the ability of the patient to make relevant changes of his or her care. So you are not able to motivate the person to get into this your treatment practice properly and to adhere to the medication. Depression may be associated with poor blood glucose control, irrespective of the behavioral action. This may lead to hopelessness, guilt, loss of empowerment, decreased sense of controlness, and may influence motivation of the patient to engage in further clinical treatment and recommendation. Unsuccessful, the clinicians may unwittingly blame the patient for a situation the patient now has a little control over. This means that sometimes we uh, do not respect the patient's complaint. Rather, we tell that you are not adhering. But why the patient is not adhering? So there may be reason behind it, maybe depression. And commonly associated with difficulty organizing in the stack. So we think that that patient is having some cognitive impairment, but it may be pseudodementia, and so patient is not able to understand, because patient able to not able to understand this what the command we are giving. It may be the patient is due to depression. Depression leads to more pessimistic view of the future, and clinicians may need to help depressed patients break down to manageable actions that may have shorter term payoff reduction of the physical symptoms. And depression is commonly associated with anxiety, because anxiety and depression is very well comorbid, and clinicians need to consider presence of anxiety in patients when after decision making, and increase the general sense of dread about the likelihood of the success. So you have to go for screen for depression patients with the screening tools like patient health questionnaire, and Pfizer has sometimes given with Prime MD and DSM-5. Helplessness, giving up, sense of being overwhelmed about the disease, and self-management, comorbid panic attacks, and post-traumatic stress disorder, inability to differentiate anxiety symptoms from the diabetic symptoms like hypoglycemia. Sometimes this is hypoglycemia. Sometimes patient is not taking food but taking this medicine. But many people sometimes advise accordingly and associated eating concerns, that is what to take this medicine, what to not take this food and other things. So this also contributes some of these problems of this depression. And emotional eating in response to sadness, loneliness, anger, and binge eating or purging, and sometimes the people are having night eating also. So improve self management, that explore this loss of control of the disease, self management, and explore understand a bidirectional link between stress and subordinal disease, self management, and outcomes. What sometimes what Dr. Jain sir has discussed about some of these things, and define depression, how it overlaps with the distinct from this also stress. So stress is this a manageable thing, and we can reduce amount of the stress by different coping methods. But depression is mostly is a biological phenomenon where there is the problems in the neurotransmitters like serotonin or dopamine or norepinephrine. So discuss the patient depression related medical complications and medical symptom amplification, because sometimes the symptoms are amplified due to depression. Patient telling that I am having so much of symptoms, but clinician is not finding that amount in this physical finding. So breakdown talks of the self-management of the diabetes, depression, other illnesses, and help the patient prioritize order of importance with specific task. So then support this patient to consider adjunctive brief psychotherapy with emotional psychotherapy like cognitive behavioral therapy, breaking down the problems like problem solving tools, and improving treatment as well. So this is most important thing is that we should give some amount of the time, because in the PG practice now most of the time you see around 100 patients per day. So there is lack of time to spare for this healing practices of this patient. So that is very much important, that we should understand the patient's emotion and also advise this patient's caregiver accordingly. Then consider medications. So sometimes comorbid depression and anxiety, we use SSRI or SNRI. You all know about all these different types of SSRIs and SNRIs. And when there is sexual dysfunction, we may use bupropion and buspirone if the patient is already responding to one of these medication or side effects are there. Then significant neuropathy sometimes associated with this patient, then we may change this medication from SSRI to SNRI or venlafaxine or duloxetine, because most of the people also use duloxetine for the effectiveness in the treating neuropathic pain. And you must be agreed that dosulapine and also amitriptyline are very commonly used by all the people for this neuropathic pain. So this is one of the slide to share that if we treat this depression in the patient with diabetes properly, so healthcare cost is decreased for over the period of 2 years patients. So if you do not treat this patient depression, then patient will repeatedly go to the hospitalization and repeatedly go for different investigations, anxiety symptoms and depression symptoms actually is very much prevalent is there, and patient comes very frequently to the physicians, and increase cost burden to the healthcare cost increases. So another important slide is that I wanted to show you, although it is a very old study, but there is a strong association between found between depression symptoms and increase mortality in the patients with diabetes. So depression is there with the diabetes, then there is much more increased mortality in the population. So in the summary, I must tell that whatever we have right now pointed out, that one third of the people suffer from the depression with the diabetes. Depression is also a risk factor for the diabetes. So two-thirds of the people suffering from depression, they suffer from diabetes at one point of time, and symptoms of diabetes share some of the symptoms of the depression for that reason. So you should take care of these symptoms, otherwise we will actually biased by the patient's complaints, and depression affects and complicate the outcome of the treatment of the diabetes also. And people suffering from the diabetes should be screened and treated adequately for the depression, and proper treatment of the depression along with diabetes can improve treatment adherence, quality of life, and also the reduce mortality. And lastly, Jain sir and sir has already pointed this topic, that spirituality helps both for the depression and also for the diabetes. Thank you all.